Thank you very much, Dr. Makanda. The Vice Chancellor here ably represented by the Deputy Vice Chancellor Academics, the Chairman of this occasion, and my teacher, Professor Kanimo Estes. Yes, Estes. The Provost, College of Medical Sciences, Professor Ngum. The Deputy Provost, College of Medical Sciences, Professor Akian. My own Chief Medical Director, Professor Mfeme, distinguished professors and academicians from different specialties in the hospital and the university, ladies and gentlemen. I'm privileged to give this lecture, and they say anesthetists have come to resuscitate. We are known for resuscitation. We are not just known for putting people to sleep. Whenever there is need for resuscitation, get hold of an anesthetist. In the few minutes allotted, I would like to take us through the two subjects. And in pain, I want us to go through the definition of pain, pain transition pathway, the transition theories of pain, and types of pain. When I'm talking about pain management, I would like to take us through pain assessment and the pain assessment tools, the World Health Organization analgesic ladder, pharmacologic and non-pharmacologic approaches to pain management. I'll talk about the pain clinic and our contributions in this area of study. Permit me, the Vice Chancellor, in the course of my discussion, I would like to make some recommendations which I believe will further this area of care, both to our patients and to us as academicians. I'd like to make some disclosures. I have suffered pain, managed pain, and taught pain. I've gone through labor pain and recently pain from sciatica. A great part of my professional life has been spent providing analgesia and anesthesia, and I've been teaching undergraduate medical and dentistry students pain management for several years. As a way of introduction, I consider myself most privileged to give this lecture. The choice of the topic didn't sound very floral to me, because these kind of celebrated lectures are usually fraught with very beautifully sounding topics. So I thought that this was not floral enough. The faculty lecture series committee actually sent letters to all the departments to select 3 topics and a lecturer. And so we selected 3 topics. I felt the other 2 were more like the kind of lectures that will be presented in fora like this. But we chose this one. I discovered that they were right and I was wrong. Right because, as has been said by all the previous speakers, pain involves all of us. And we are here today to talk about it. When we talk about pain, we say you are either infected or you are affected. In pain management, I know that we are all involved. And in the course of this discussion, I believe that you're going to know where your involvement is, how you are getting about it, and how you can improve your involvement. Definition of pain. Pain comes from words in Latin and Greek, meaning suffering, punishment, penalty. But the International Association for the Study of Pain published a definition for pain management. I know my students will be wondering what I'm saying today. It is slightly different from what I've taught them in the classroom. In 2020, the former definition of pain was slightly modified to mean an unpleasant sensory or emotional experience associated with or resembling that associated with actual or potential tissue damage. Like my teacher, Professor Asindi, taught us, action words, unpleasant, sensory, emotional. Now, the pain pathway. I was cautioned by the chairman of my committee that I should not make this topic very technical because we have lay persons among us. I'm also aware that we have Rotarians among us, and they usually say we should be fair to all concerned. That is what I intend to do. A little technicality and a little for everybody. At the end of look at this diagram, you will see somebody has hit the leg. There are pain signals. They are picked up by what we call nociceptive fibers. They are the A delta fibers and the C fibers. They carry these signals to the spinal cord. In the spinal cord, they move to the other side, say they deposit, and then they continue to ascend right up to the thalamus, and from there they get to the somatosensory cortex, where pain is perceived. Now, I want you to take note of that place just after the ball, that which I had a pointer. That is called the substantia gelatinosa. In that place, we have the lamina 2, where there are interneurons. They are stimulated by thought, pressure, temperature, and these activate a different set of fibers. I talked about C fibers and A delta fibers carrying the pain signal. Now, other signals are carried by A beta fibers. These are touch signals. And what do they do? They have inhibitory neurons that they stimulate to stop the pain. So we are talking about pain modulation. So at the level of the spinal cord, we have what is happening at the substantia gelatinosa that is stopping the pain. What does this translate to? It means that that pain that you have, and you just instinctively put your hand and begin to rub. That rubbing is setting up another signal to go and block the pain. On the descending pathway, we have from the reticular formation things that we call neurotransmitters. Serotonin, noradrenaline, they get down to the spinal cord and they release pain medications called them so. We call them endogenous opioids, enkephalins, endorphins, and glycogen. These are the inherent way the body stops the pain. Why do we bother about pain? We want to enhance the patient's comfort. If the patient is in the hospital, we want to reduce length of stay in the hospital. We want to minimize stress response. We want to reduce the risk of acute pain progressing to become chronic pain. Sometimes people just have a little acute pain, but if it is not addressed, it can progress to chronic pain. Now, several studies have been carried out. One of them in Ibadan revealed that only half of the patients in pain in the emergency department receive any anesthesia at all. And among those who received anesthesia, 80% were still left with moderate to severe pain. Madam Chancellor and my CMD, I want to tell you that in the course of preparing for this lecture, I sent a resident round the whole hospital to look at the DPA covers. There was a time we had, we no longer call them dangerous drugs, we call them controlled drugs. Drugs like morphine, fentanyl, and in the and it is a must. Unfortunately, I found out that only 60% of our wards have a controlled drug cover. This is an area we need to address. There are consequences of unrelieved pain. Unrelieved pain can increase the heart rate, increase the blood pressure, increase the cardiac workload. Now, while this happens for most people, in a small percentage of people, we can actually have a reduced blood pressure, a reduced heart rate, a reduced cardiac workload, and the patient can have symptoms. The patient was faint because of severe pain. In the respiratory system, all of us know it. You can be in so much pain that you don't even want to breathe. You can barely breathe. And when you don't breathe well, those small air sacs in your lungs get closed. We call it atelectasis. What does that translate to? The oxygen in your bloodstream reduces. You have a risk of pulmonary infection. And all the systems are involved. It all boils down to poor patient satisfaction. Psychologically, anxiety, fear, frustration. Now, the pain transition theories are very interesting, and there are many of them as listed. But I'd like to take us through the Cartesian dualistic theory. He says that throughout the history, religious ideologies have had a substantial influence on people's thoughts and actions. And pain could be a result of physical injury or psychological injury, but the two did not influence each other. In an attempt to placate the church, Descartes, who propounded this theory, also included in his theory that pain has a connection to the soul, and that the soul of pain was the pineal gland, and the brain, the moderator of painful stimulation. But very importantly, we have the gate control theory of pain. This evolutionary theory by Patrick and Melzer was proposed in 1965 spine. It's still compared to that substantial teratonosa in the dorsal horn of the spinal cord. Here, pain signals are modulated. What does the gate do? The gate can close or the gate can open. What closes the gate? Please go on 2 slides ahead. What closes the head gate? What opens the gate? The gate can be opened at intense pain stimulus. No matter what I say, you give your toes. You still begin to rub it. So the signals from the thought, if they are more than the signals from the pain, they can go and block the pain pathway. So you can have the pain gate can be opened by intense pain stimulus. It can also be opened by depression, by fear, and by anxiety. Because if you look at that pain pathway, there are still some linkages to the limbic system, the seat of emotion. What closes the pain gate? Massage. Trans-electrical nerve stimulation. Positive attitude. That is why I say we are all involved. And then there is an anesthesiologist, Joseph Bonica. He is the father of pain medicine. He is the one who propounded that pain has a complex interaction between biological, psychological, and physiological factors. What does this translate to? It means that the pastor, the doctor, the neighbor, everybody is involved in pain management. So in that common stretch that we saw, a young lady goes to see the doctor. She did not have money to pay for medicine. Imagine if the neighbor gave her money. She would have been out of the embarrassing situation she found herself. And by the way, doctors don't collect money before they manage pain. You pay the hospital bills. Types of pain. There are different ways of classifying pain. Pain can be classified based on duration, based on pathophysiology, and there are other classifications. But in this discourse, we are going to talk about the classification based on duration and based on pathophysiology. Now, based on duration, pain less than 1 month is called acute pain. It usually has an obvious tissue damage, the result of bleeding, and it serves a protective function. And acute pain settings could include things like post-operative pain. Somebody has had surgery. That is an acute pain setting. Somebody is on the ward having wound dressings, burnt wound dressings, and so on. Somebody is on the medical ward has had a myocardial infarction, a sickle cell crisis, and labor pain is also a form of acute pain. Now, chronic pain is pain lasting more than 3 months. It is multifactorial. It has psychological factors, so there is depression, there is anxiety, there is somatization, which is why our cough and the rest of the team from the neuropsychiatric hospital, very ably represented here, are very important in the management of pain. There are socio-economic factors. It has been reported that even in multicultural societies, people of certain ethnic groups report pain less because there may be a fear of pain. You have patients in the labor ward who are in intense pain, and all they do is they tap the toe because they are from a certain ethnic group. There is an abomination for a woman to complain of pain. There are also spiritual factors. And I thank the Presbyterian family that are ably represented here. Chronic pain. Chronic pain can be chronic primary pain or chronic secondary pain. Chronic primary pain is that pain that you cannot trace the pathology. And in that kind of pain, you don't even start feeling analgesic. That is the purview, that is the kind of patient, once you diagnose that this patient has got chronic primary pain, you send the patient to the psychiatrist and the psychologist, they will know what to do. But chronic secondary pain is pain that is secondary to something. It can be due to cancer, can be due to HIV, very commonly, and the others that are listed there. Now, based on pathophysiology, you have nociceptive pain, neuropathic pain, and nociplastic pain. Now, look at this as an alarm. Pain is an alarm system. So you look at it that what is the commonest alarm? Maybe a fire alarm. So the smoke detector will detect that something is wrong. That is nociceptive pain. The pain is caused by an injury to body tissues. Or if you live in societies like the US, the UK, where you know you can actually, and even in this country, in some places, the burglar is coming to your house, the detector, your alarm can detect it and set off. That is an analogy of nociceptive pain. Neuropathic pain is pain that is caused by a primary lesion to the the central nervous system or the peripheral nervous system. Muscular pain, on the other hand, or if you want to look at the neuropathic pain in terms of the alarm I was talking about. In this case, the problem is with the alarm itself. The problem is with the alarm itself. So when you talk about muscular pain, there are changes in the pain system, despite healing and restoration because of fear and the memory of past pain. Now, muscular pain can be likened to a problem in the pain center. So the place that is kind of, analyzing all the data that is coming from the alarm is where the problem is. We can have mixed pain, a mixture of any of these or all of them. What are the patient descriptors for the different kinds of pain? If you have pain, the patient will describe the pain as aching, sharp, throbbing. In your battle pain, the patient talks about burning, tingling. The patient, something is cold, it's excessively cold. Something is hot, it's excessively hot. So there's hypersensitivity to hot or cold, or heat or cold. Then the other pain perceptions we can talk about are retail pain. So there's pain in a perceived in an area other than the site of the painful stimulus. The patient has got a heart attack, and the patient has pain on the left shoulder. That is why you should see a doctor. But when you go to the chemist, they are going to give you that thing you need to give. They mix a drug, glutamine, all those things. And you eat all of them, and you come down with the side effect. Pain means a lot, and the doctor is licensed and trained in the art of diagnosis. The pain on the shoulder may actually be that you have an impending heart attack. Then there's phantom limb pain. This is limb pain from a non-existent limb. So somebody has had an amputation, the hand has been amputated, or the leg has been amputated, but the patient is having pain in the limb that has been amputated. That is phantom limb pain. And leukemia is pain due to a stimulus that does not usually cause pain, while central anesthesia is increased pain from the stimulus that usually causes pain. You go on to pain management. As doctors, as clinicians, you know that in managing any condition, you take a history, you examine, you do an investigation, establish a diagnosis, and you come up with a treatment plan. How do we take pain history? You can have a memoirs. For example, Socrates, or we all do ECG. We can use the dual testing, and then we know so that we don't leave out any aspect that we need to consider. So in the pain history, we talk about the site, the onset, the character of the pain, the radiation, the association, time course, exacerbating and relieving factors, and the severity of pain. Based on the presenting complaints of the patient, you go on to inspect, calculate, enforce, and auscultate as necessary. Documentation of pain assessment as a vital sign is very important. I'm very happy that we have a large number of our nursing colleagues here. In our study, we found that 41% of clinicians always document pain assessment, but a greater proportion of our respondents rarely or never document pain. Pain scores have not been given their pride of place as the fifth vital sign. We need to constantly document pulse, blood pressure, respiratory rate routinely. We need to begin to document pain scores routinely in our patients. Thank you, our nurses, for helping us out. What are these pain assessment tools? A very simple pain assessment tool is the numeric rating scale. This pain assessment tool is one of the unidimensional assessment tools. In this tool, you tell the patient on a scale of 0, meaning no pain, and 10, meaning the worst pain imaginable. How much pain are you having? Our studies have shown that patients are usually consistent. For example, the patient says, I am having 8/10, and you give an analgesic. If the analgesic is effective, by the time you come back and say, how much pain are you having? The patient will say 3/10 or 5/10. And what you want to achieve is maybe a 0 or a 1 or a 2/10. Then you know how to either increase your medication and so on. There is a verbal rating scale, another unidimensional pain scale. On a scale of 0, on one end meaning no pain, and on the other end meaning the worst pain imaginable. Very commonly, this before we say mild, no pain, mild pain, moderate pain, severe pain. The important thing is that be consistent in the pain assessment tool that you're using. We also have a FACES scale. The Wongeta FACES scale was originally made for children, but it's also made for pre-verbal and non-verbal people. So you can look at the faces. On one end you have a smiling face, a happy face, and on the other end you have a crying face, and the patient should be able to say on the scale how much pain is having. Note that pain assessment is subjective, and as a clinician, you must believe the patient's report. You are not the patient, so you cannot determine how much pain the patient is having. It is said that pain is subjective, so you must believe the patient's report. We also have the flat scale where you look at the face, the neck, the activity, the cry, and the consolability. We use this in pediatrics for the pain. Then the multi-dimensional pain scales. We have the McGill pain questionnaire. In this McGill pain questionnaire, there are about 78 parameters that are grouped in 1 to 10 somatic in nature, 11 to 15 affective, and the rest evaluated. You put all this together and you determine how much pain the patient is having. You also have a pictorial view where you can actually indicate where the pain is. Remember that one patient will have more than one pain. So somebody with arthritis can suddenly develop abdominal pain. So we must assess each pain on its own merit. Because of the long McGill pain questionnaire, it also has a short form. Now, for neuropathic pain, we have neuropathic pain screening tools. These will assess symptoms such as pricking, tingling, pins and needles, electric shock, shooting, pulse or burning, numbness. These are the characteristics of neuropathic pain. When the patient is having such symptoms, you know that something is wrong with either the central or the peripheral nervous system. We go on to the WHO analgesic ladder. Now, when you have decided that your patient has got pain, what will you do? I usually liken pain management to glycemic control. When we started as house officers, it was very difficult to do a blood sugar analysis for a patient. And we were running left and right. But today, almost every patient has got a glucose meter. Now, for the WHO analgesic ladder, you look at the pain on a step-by-step basis. So, if you look at this ladder, you will see the arrow going up, talking about chronic pain. Why is it so? Chronic pain starts low and gradually increases as the disease progresses. Let's take an example, cancer pain. Somebody has got cancer. It starts as a small lump, and before you know it, there's metastasis. So the pain that was very minimal gradually increases. On the other hand, active pain usually starts maximally and then it increases. Take, for example, post-operative pain. The first day of the operation is the most painful because that is where you have the highest tissue damage. If you go back to the International Association of the Study of Pain, definition of pain, talking about tissue damage. So, as we are going down and the tissue is healing, the pain is reducing. So, what do we do on step 1 of the ladder? We give non-opioid analgesics, paracetamol, non-steroidal anti-inflammatory drugs like diclofenac, like ibuprofen, and the rest of them that we know. By the time the patient gets to step 2, we are talking about weak opioids. Weak opioids are drugs like tramadol, pentazocine, codeine. But by the time the patient is having severe pain, that is when we need to start giving the patient stronger analgesics, morphine, fentanyl, pethidine. And the pain still persists, we need to up the game to interventional treatment. Nerve block, patient control analgesia, spinal cord stimulation, and all of that. Opioids are the mainstay of acute pain management, and they work in different receptors. If you look at this, two steps ahead. Yes. So if you look at this slide, you'll see that pentazocine is a partial agonist. This is my pharmacology colleague and my clinical colleague to understand it. It's a partial agonist at the mu receptor and an agonist at the kappa receptor. What does that mean? It means that you have a ceiling effect. Unfortunately, our studies show that this is the highest analgesic that we are giving to our patients. After this lecture, I want us to talk again. Opiate use. Many patients do not receive adequate pain relief because of poor understanding of the drug by both patients and staff, and of course, unavailability of the drugs also. And studies show that 73.1% of our clinicians have managed to get paid in the past 6 months. But they were using pentaclocine, tramadol, codeine. Whatever happened to morphine, peptidine, fentanyl that is recommended by the LADA for severe pain? In Uganda, they found that 2/3 of patients complained of moderate to unbearable pain 24 hours post-operatively. And in Uganda, they found that only 45% of clinicians always had peptidine and morphine available. My Vice Chancellor, sir, and my CMD, it is time for us to engage the opioid control office at somewhere in Lagos, so that we can get opioids available for our patients. Now, what are the rules of administration of opioids? Opioids can be given intramuscularly, intravenously, subcutaneously, by patches, and so on. Very commonly, people give opioids intramuscularly. That is not bad. What is bad is that they give it on a PRN basis. That means as the patient requires. What does it mean? So a patient feels pain and the patient calls the nurse. There is one nurse looking after 30 patients on the ward. The nursing and midwifery council used to say 1 nurse to 6 patients. Thank you, my CMD. I know that you have deployed it, but we need more. So it's supposed to be 1 to 6, but we have 1 nurse managing 30 patients. So studies have shown that sometimes it takes as much as 2 hours for a patient, from when the patient complains of pain to when the pain intervention is done. This is wrong. The plan and answer of the PRN doses make sure that you have a roller coaster plasma level of the dose. So you don't have a steady plasma level of the opioid that can give adequate pain relief to your patient. What do we recommend? Fixed interval. If you're prescribing pain medication to a patient, please put a time to it based on the duration of action of the drug. When the drug acts for 6 hours, give the drug 6 hours. The drug acts for 8 hours, give the drug 8 hours. The drug acts for 4 hours, give the drug 12 hours. But by no means, don't prescribe pain medication PRN. I'll tell you when to prescribe pain medication PRN. Intravenous infusions need to be given to patients in monitored areas. So if you are giving intravenous opioids to a patient, please make sure the patient is in the post-anesthetic unit, in high-dependency unit, or in an intensive unit. My CMD, sir, sorry, I will have to come because we have monitors in the hospital that have optional accessories for patient control and analgesia. All what you need is to buy this optional accessories. What does it do? It puts the patient in control of his pain. So when the patient has pain, instead of calling somebody and it will take a long time for the person to come, the patient just presses the button and self-administers the dose. Don't worry, the patient is not in control. The doctor is still in control. The doctor will prescribe the kind of drug. The doctor will prescribe how much drug then the patient gets the doctor. The doctor will prescribe the knockout interval to ensure that the patient does not get and overuse. Now, I've talked about the transdermal, we go to breakthrough pain. Now, this is where you can give a PRN medication. If you have already prescribed drugs for your patient, remember that you are monitoring your patient and you are going back to monitor the patient. It is not enough to just prescribe and go away. When we started, I started sending my residents to the ward to do post-anesthesia review. And you know that I am challenged with that. And somewhere when I was telling my success story, somebody was asking me and said, they are crumbling. My residents are here. I know that you have problems with that. But what am I saying? It is not enough to prescribe pain medications to a patient. Go back and monitor. How is this patient? Is the pain medication effective? Do we need to increase it? That has side effects? Do we need to reduce it? And all that. So when a patient has breakthrough pain, in between the fixed interval, you need to now prescribe the drug PRN. And you give between 5 and 10% of the 24-hour dose of the analgesic. We have the concept of preemptive analgesia. This is well known to anesthetists. First time you have prophylactic antibiotics, you give the analgesic in anticipation of the pain. So you know that the patient is going to have surgical incision. You know that surgical incision is painful. So we give the analgesia preemptively before the skin incision. The obvious side effects are well known to those of us who are using food, but the most dreaded one is respiratory depression. Never mind. We have oxygen plants in the teaching hospital now. If your patient is having respiratory depression, give oxygen. If you don't know what to do, call the anesthetist will be able to manage it for you. Please, wherever patients are being used, let's make sure that we have naloxone, which is antidote. Look at the same exposed area. It is an antagonist at all the receptors for opiates. We move on to non-opiates, non-steroidal anti-inflammatory drugs. We are all using them, like diclofenac, ibuprofen, ibuprofen, Theradine, aspirin, and all that. This is a group of drugs to know. And we also have, these ones are called the cytokinase inhibitors, don't mind the big English. We also have the selective cytokinase inhibitors. What does this translate to? The earlier drugs cause gastric ulceration, bleeding, allergy, edema. So if you have a patient with peptic ulcer or bleeding tendencies, they are not good drugs to use. But the other drugs, the celecoxib, the ribofloxacin, they are potent anti-inflammatory drugs and also have an analgesic effect, but they do not have the anti-platelet effect, and they have less gastric ulcers, so they can be used in those patients. We have other drugs like ketamine, dextromethorphan, and we have gases that we can use. So if you have a gas that called ethanol, can actually use it in obstetric analgesia. It's a combination of oxygen and nitrous oxide in 50-50 percentages. So the patient has a demand valve and is in labor, we put it on the face, and the patient breathes and is pain-free during labor. There are no anesthetic techniques. These are a little more technical. If you do an analgesia, some of you have had it, we do an injection at the back, we put in a catheter, and then we get the catheter up to your shoulder so that we have access to it. We can continue to top it up and give you pain-free post-operative period. So you see, somebody has surgery. In fact, I had surgery, and I went home, and somebody came and said, come and give an anesthesia to the child. I said, sir, I just had surgery 2 days ago. He said, it's a lie. I said, I just had surgery 2 days. He went to me because I was pain-free. Almost everything in the body, almost every nerve in the body can be blocked if the right facility. Now, there are adjuvant drugs that can be used. Adjuvant drugs are drugs that have indications apart from analgesic properties, and they are usually co-administered with other analgesics. And they are mostly helpful in patients with neuropathic pain. Those patients that are having shocking sensations, pains and needle sensations, those are patients with neuropathic pain. Psychiatric antidepressants, serotonin receptor antagonists, neuroleptics, alpha blockers, antispasmodics, muscle relaxants, and the rest of the drugs as listed there are the adjuvants that we use in such cases. We have non-pharmacologic management of patients. Trans-electrical nerve stimulation, acupuncture, acupressure, music therapy, magnetic therapy, and then psychotherapy, physical spiritual support, prayer. All these are effective in pain management, but the literature shows very efficacy of all of these techniques. And I'm happy that my physiotherapy colleagues are also here. So, what did the pain management expert recommend? A multimodal approach to pain management. A multimodal approach. If you look at this is still that same pain pathway that I talked about. So we can take drugs instead of taking one drug and giving the patient. Here you can have a large amount of side effects. You can have drugs that are acting as transduction, transmission, and modulation and perception. So the drugs are acting at different levels in the pain pathway to give analgesia to the patient. Next slide. So you see here you're giving one drug, you have to give a lot of it, and then your drug will be side effect. So that if you're giving a lot of drugs multimodally, you give a little of it, and you have little side effects of it. That brings me to the subject of the pain clinic. I'm very happy that in the past, on the 1st of February this year, we opened our pain clinic to the public. Now, the pain clinic is where you can have pain management that involves medicines, lifetime medication, nerve blocks, and physical therapy. What do? The patient comes to the pain clinic to pick an appointment. On the appointed day, you come and a history is taken. Evaluation is done. And it is decided, do you need pharmacological methods of management or non-pharmacological methods of management? And at the end of the intervention, the patient can be discharged from the pain clinic or be assessed for further pain. This is our pain clinic, and this is our pain clinic nurse. We recommend that patients with chronic pain should have their pain medication by the mouth. The patient who is living with pain, you cannot put the patient on injectables. It's not practical. So a patient that is living with chronic pain, as much as possible, should have the analgesics by the mouth. By the glove, that means at fixed intervals. By the ladder, that means the patient has got mild pain, you give medication for mild pain. Has got severe pain, you give medication for severe pain. Guide the patient should be put in control of their pain. Remember what we said, that pain is whatever the patient says it is, and exists wherever the patient says it does. You must pay attention to details of the patient. Now, if you remember what I said, that pain is an alarm. Don't just stop the alarm. So you have a fire alarm in the house, and you just go and switch off the alarm. What happens? Fire will burn the house. Don't work in places where we have alarms all over the place, in the critical care unit. You must always know the reason why the alarm is set off. So you have an oxygen failure alarm, if you not attend to it, the oxygen will get finished, and your patient will die. Somebody say God for me. So don't just stop the pain. Don't just stop the alarm. Find the cause and treat. The definitive treatment can be medical treatment. Somebody we talked about somebody with a heart attack or an impending heart attack. Medical treatment. Somebody has got sickle cell crisis, and so forth and so on. It may be surgical. The person needs surgery. It may be palliative care. You must take note that end of life care sometimes involves a lot of pain. And we should not just watch our loved ones dying in pain. There is what I call dying with dignity. Somebody should die knowing that his relatives care for him. Somebody should die pain-free. It doesn't mean that because the person is dying, the person should die in pain. So what have we contributed? My former provost used to say that the Faculty of Clinical Sciences or the College of Medical Sciences is like a hospital, is like a laboratory. So, we render clinical services to carry out training and research. We did this study on attitude of Nigerian mother towards labor pain and its relief. And we found that 95.5% of the patients were not aware of any method of pain relief in labor. And the remaining ones were just aware of peripheral progress. Now, among those patients who were just coming out of labor, 84.6% of them were screaming their head off during labor as they accepted. But only 51.7% said that they will accept the epidural in subsequent labor. We concluded in this study that ignorance, religion, and sociocultural beliefs are contributors to the poor attitude of Nigerian men towards labor pain and its relief. We did studies on pain in AIDS, both in Calabar and in New York. We found out that the prevalence of pain is quite significant. But more importantly is that patients have multiple sites of pain. Most patients with AIDS have multiple sites of pain. And only 32.4% had any analgesia prescribed for them. 60% of the patients with severe pain had no form of analgesia prescribed for them. So the pain management in AIDS we found is inadequate. And we concluded that pain is a significant and debilitating symptom affecting multiple sites concurrently in patients with HIV/AIDS and is grossly undertreated. We also propose that involvement of pain specialists in their management to bring about improvement in the overall quality of health care for these patients. Now, I'm trying to talk about some of our findings in our ongoing study, so I will skip this. I also want to remember when I was a senior registrar and I became passionate about post-operative pain management. And some of the people sitting here have been my patients. And I will do the epidural and send the patient to the ward. we were able to have the base for